Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth. I will be your host for tonight's program on men's health. We will be glad to take your calls on men's health-related questions in general. The success of this program is very dependent on you, the viewer, so please call in your questions and we will do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Roger Miller, a urologist with St. Luke's Urology Associates, Dr. Jake Prunuski, a family physician at the Lake Superior Community Health Center and a faculty member in the Department of Family Medicine and Community Health at the Medical School Duluth, and Dr. Paul Tonkin, a urologist with Essentia Health and a former medical student at Duluth. Welcome back, Paul.
Thank you.
Our medical students answering the phones tonight are Tom Kaminsky of Elk River, Ben Meyer of Grand Rapids, and Ben Weirs from Annandale, Minnesota. And now on to tonight's program on men's health. Dr. Prunuski, from a family physician standpoint, can you tell us a little bit about what you consider men's health to include?
Well, to me, health is being able to do what you want, when you want, with limited or no limitations. And when I think of men's health, I think of those issues which are either unique to men due to how we're built or disproportionately affect men relative to women or kids or other people in the population.
Taking that a step further, Dr. Tonkin, how does a urologist look at men's health?
We certainly look at those things as well. We were certainly trained with different skills in terms of surgical intervention, looking at men's voiding function or dysfunction, things like enlarged prostate and how that would affect voiding. Certainly issues that pertain to sexual health, erectile dysfunction, which is very common as men get older. And then of course cancers that occur in men as they get older as well, prostate cancer being the most common.
Dr. Miller, one of the plagues of society, if you will, is smoking. And I know that smoking has its effect on men's health too. Could you elaborate a little bit for us?
In addition to the general things that smoking can affect, that is progression of heart disease and injury to the lungs. Specifically for the urologist, we find that smoking can adversely affect a man's erectile function, in that the smoking will contract the blood vessels, cause blood vessel disease, cause poor blood flow for the penis, and alter his erections. Additionally, men who smoke have an increased risk of developing bladder cancer, as do women.
Dr. Prunuski, when you counsel men, and that's kind of one of our jobs as primary care physicians, what kind of preventive discussion do you have with men? Let's pick an age, I suppose, considering our audience, let's say 60 years and older.
Well, I mean, at 60, there's some simple things like immunizations, tetanus booster, shingles vaccine. Not at 60, but at 65, I'd think about a pneumonia vaccine, and for all men, a flu shot. But one of the biggest conversations we have at that age revolves around colorectal cancer screening, prostate cancer screening, and then also general health. The leading cause of death for men in this country is heart disease. And so I think of, well, what can I do to help identify any individual man's particular risk for heart disease? Do they have any signs or symptoms that make me more suspicious? And then there are things that that man and me as his physician can do together to try to reduce his risk for problems related to heart disease in the future.
When you talk about vascular, and Roger, you talked a little bit about the vascular system also. There's a lot of discussion today and finally a recognition that erectile dysfunction may well be related to poor vascular flow and a predictor of coronary disease. Is that correct?
Very true, because the blood vessel disease that affects erectile function certainly can affect other blood vessels in the body. The blood vessels for the heart, blood vessels going to the brain, and also blood vessels to the peripheral, to the legs. All these things can be affected in various different ways and at different rates, and it behooves the physician when he sees a person to look at all of these things.
Jake, this is from Chisholm, Minnesota. Should I be doing a self-testicular exam?
That is a little bit age dependent. I mean, there's almost no risk to doing a self-testicular exam. Certainly testicular common is most common in younger men. I think of this as a disease primarily of the late teens and 20s into the early to mid 30s. Beyond that, testicular cancer actually becomes much less common. So for a younger man, certainly this is something that they should do. For an older man, if they were to notice an abnormality on the testicle, it's certainly something that warrants attention. They should, talk to their doctor about it, be evaluated.
Other comments?
I mean, certainly testicular cancers are most common in young men, but they can occur throughout life. And as men get older, one of the cancers that can develop in the testicles is lymphoma, which is certainly common in older men. And so in general, the more engaged a man can be in his health, I think the better off he is.
I think it's also true that the audience ought to know that with testicular cancer, we have made great strides in the last 30 years in both surgical and medical treatment of testicular cancer with chemotherapy. If we go back to the 60s and early 70s, the survival rate of any men with testicular cancer was abysmal. But with the addition of new sorts of chemotherapy in the mid to late 70s, the survival rate has increased remarkably to the point where it's 95% curable.
Lance Armstrong?
Yes, Lance Armstrong had a very unusual and aggressive sort of testicular cancer with spread into his brain and was cured with chemotherapy.
Any of you, but probably Jake, what do you think about wives directing their husbands' health care? It's a great question.
We were talking about this before the show started. The last time I looked, and this is probably 4 or 5 years ago, in the United States, men who are married have, on average, lived 5 years longer than men who are not, probably due to encouragement from their partners to get them to seek health care. As far as I know, this study hasn't been done looking at same-sex partners, but I think in general, heeding the folks who love you when they're saying, look, you need to see someone is not a bad idea.
Agreed?
Agreed.
Paul, what are the current PSA screening recommendations? And we talked a little bit about this before. You have the AUA, and we also have the American Cancer Society. I'm not sure, do we use the Preventive Task Force in family medicine? Anyway, have a go at this.
Yeah, I mean, this is certainly one of the really hot topics in urology and medicine right now. Prostate cancer is still the most common solid organ cancer diagnosed in men. It's still the #2 cancer killer in men, representing 35,000 deaths annually in the United States. So from that standpoint, it is an important and pertinent topic. There have been some confusion in terms of what the recommendations currently are, as there are multiple groups with different recommendations. In short, the American Urological Association still recommends that men age 40 talk to their physician about being screened, and after that discussion that they be offered PSA and DRE, which is digital rectal exam screening, as long as they're healthy men. The American Cancer Society has a similar recommendation. Their start age is around 50. Men who are at higher risk, namely African American men or men with a first-degree relative with prostate cancer, that being a father, brother, son, be offered screening earlier. Now, the great debate has come up with the U.S. Preventive Task Force, which is basically more or less recommended a one-size-fits-all approach to prostate cancer, which I think at least the three of us certainly agree is inappropriate, which is basically that they're no longer recommending PSA screening for men. And one of my concerns with that is that that's going to have a ripple effect amongst men in the sense that, one, it gives a message to men to not see their healthcare provider. And then number two, I've certainly seen men, due to a concern of an elevated PSA, I saw that PSA value, wasn't really concerned about it, but then asked these questions that we were talking about, how are your erections, how's your love life, how are things at home? Oh, yeah, by the way, I'm 50 with erectile dysfunction. Oh, by the way, I get chest pain when I shovel snow. Send them to Jake, and all of a sudden you potentially, you're not going to save that guy from prostate cancer, potentially, eliminate an early death from cardiovascular disease.
And just to build on that slightly, the U.S. Preventive Services Task Force isn't saying to not do prostate cancer screening. What they're saying is that at a population level, they can't show that screening is clearly beneficial. There's concerns that people are potentially harmed by screening, but that's at a population level, and those decisions are used to make decisions for large groups. Sometimes what's best for a large group is different than what's best for any one person. And so I think, just like when the recommendations changed for women with breast cancer screening, the message isn't not to get screened. The message is just that routine screening for every man may not be appropriate, but for any one person, for each man who's watching the show, there's a right decision to screen or not screen. That's different than a population recommendation.
And I certainly hope that that's the take-home message, because I've had a lot of patients come to me and they basically say, I'm no longer supposed to see my doctor to talk about prostate cancer, and that's one of the thing that's very difficult to sift through facts and myth. The facts about PSA is that it does detect prostate cancer earlier than rectal exam alone. We do detect prostate cancer at an early clinical stage. The question really is, does PSA save lives? And that's where there's some debate.
Roger, you wanted to weigh in.
I was going to say that our audience may want to know somewhat about what prostate or what PSA is. It's a material made by the prostate that shows up in the blood and can be elevated in various diseases of the prostate, either benign enlargement of the prostate, prostate cancer, or infections of the prostate. And it can, unfortunately, at the lower levels of elevation, you can't tell one versus the other. And we will sometimes go to the point of doing a biopsy of the prostate to try to figure out if a man has a cancer in his prostate, and then determine if that is an important cancer for him that will affect him during his lifetime.
Oh, go ahead.
Sorry, I think that's a very important statement. And one of the things about prostate cancer is some types of prostate cancer are slow growing, and probably all men, if we live long enough, have a chance of getting prostate cancer, but will have died of something else despite having had prostate cancer. So you have a heart attack or a stroke, or die of other causes. And the concern is if we as physicians make interventions or do things that are too aggressive for a given patient, we can cause harm as well as do good. And so the challenge for us as physicians is to identify people who would benefit from the interventions we have to offer, while not doing harm to people whose prostate cancer would have not caused them trouble in the first place. So I think the challenge is we as individuals all want a clear answer: do it or not do it. And the reality is unfortunately that there's not a simple answer. And again, I think the take-home message isn't everyone should be screened or everyone shouldn't be screened. I think the reality is that it needs to be individualized to each patient.
That's very well said. This has been a really good discussion on this topic. One of the questions I have as I listen, what about ultrasound in screening? Have there been any tests done on using ultrasound to screen for prostate cancer?
It's basically been shown to be non-beneficial. Correlating radiological studies, whether it's CT scan or MRI or ultrasound, with detection of cancers has not been fruitful and not felt to be real effective and adequate screen. And then, of course, there you end up with a lot of different issues there as well in terms of cost effectiveness and picking up on clinically significant cancers.
So waving the finger and doing the PSA and a good history.
Still as good as we have right now, but there's research being done.
We use ultrasound to guide the biopsies that we do to assure that we get an adequate sample from all areas of the prostate gland, but imaging studies have not yet been shown to be sufficiently sensitive to find cancers beyond what we have now.
Question for Dr. Miller. What causes urinary tract infection, and why does it keep coming back in a male twice in 2 years?
Urinary tract infections in men are almost always caused by bacteria which literally crawl up the channelway of the penis and set up an infection in the urine. Infections can occur in a man or a woman if there's something anatomically wrong with the urinary tract. For example, the kidneys are not draining or have stones in them, or the bladder is not emptying, or particularly in a man if there is an enlarged prostate and his bladder is not emptying, or if he has, for example, scar tissue in the channelway of the penis that could cause blockage. Additionally, some men can get a chronic infection in their prostate gland called chronic bacterial prostatitis. And even if we give a short-term dose of antibiotics, the typical 7 or 10 or maybe 14 days, the bacteria are not eradicated from the prostate, and they can literally crawl back out when the urine is cleared and set up another infection. Suffice it to say that if a man is having recurrent infections, he deserves a look to understand if there are any changeable factors such as poor bladder emptying or stones.
To carry on with the prostatitis piece, there's a question regarding chronic pelvic pain and prostatitis. What is the current theory as to its cause?
Chronic pain in general is relatively poorly understood, and what we think happens is that there's some sort of acute or immediate insult. It could be an infection, it could be trauma, and as a result of that short-term injury, as the body heals, its healing process doesn't work quite right, and the pathways that normally carry pain get mixed up such that they're sort of always turned on, and things that normally wouldn't hurt us now become painful. And as with chronic pain elsewhere, chronic low back pain, chronic pelvic pain in women, chronic pain can be very challenging to manage. Additionally, it interplays with the rest of our nervous system. So not just the sensory part of our nervous system that comes up to our brain, but our brain itself, our mood, our thoughts, how we're perceiving the world. And we know that people whom are suffering from other mental health concerns, be it depression or anxiety, actually experience pain differently than people whom aren't. And so I think if I have a patient with chronic pain, I want to make sure I'm looking very comprehensively at this patient's life and addressing each of those factors, and then working as best I can first to make sure we're not ignoring an immediate cause, and then once we've made sure we're not ignoring an immediate cause, do the best we can to optimize that patient's function in society.
Other comments? So, a little change. The question is, if you don't use it, do you lose it? And then the relationship between an active sex life and prostate cancer, especially in the elderly, but whatever.
Well, currently there is no, unfortunately for men, I don't mean to burst any bubbles out there, there's probably no correlation between, increased sexual activity and decreased chance of prostate cancer. When I say that in clinic, I often get a dirty look from some of my patients, but there really is no active correlation there. In terms of if you don't use it, do you lose it? There is some data suggesting that if you don't have frequent erections, that you can have fibrosis of the penis leading to scarring and some shortening of the penis. I see that most commonly in patients who've had surgical complications who really lose the ability to have nocturnal erections and have that inflow of blood at night, which acts as a natural tissue expander for those men. So there probably is some truth to that.
I would agree.
Okay. Roger, what causes lower semen levels in men as they age?
There is lower production merely by the prostate, which is the principal volume of the bulk of the ejaculation. It's not coming from sperm per se. Also, occasionally men as they get older, and particularly if they've had prostate surgery, the ejaculation can go back into the bladder and not forward out of the penis, and can result in a significant loss of semen volume.
Single high PSA, should it be repeated, or should you go straight to a biopsy?
It depends on that particular man. In general, it also depends on how high that PSA level is. So if I have a PSA that's 4 or 5, something that's just slightly high, I may repeat it in a month or two to see the trajectory. So it's not just a specific elevation of PSA, but where is that PSA going in time? So a PSA that's rising very rapidly in a short period of time is more concerning to me than a PSA that's gradually going up slowly over months or years.
I agree with Jake's comments. There are very many variables we use to determine if a PSA is concerning or not. One is age of a man, one is his race, one is certainly the PSA velocity, which Jake is referring to. And then the other one is PSA density, which is if you have a PSA of 3 in a very small prostate, that might be more concerning than a PSA of 3 in a very large prostate. So, unfortunately, PSA is not an easy test always to decipher, but it is worth talking to your physician about.
Highly individualized therapy.
I agree.
One other thing is that ejaculation in and of itself can raise the PSA, so the man ought to avoid having ejaculation for a couple of days before his PSA is drawn.
Good point. Let's delve into the cancer a little bit. the question is what is the treatment for a 76-year-old man with prostate cancer recently diagnosed?
I can start that, and Roger can certainly, add his comments. I think a lot of these treatments do need to be individualized. Certainly the younger the man and the higher risk cancer, the more likely it is that a urologist will recommend, surgical removal of the prostate. The older the individual man and the more medical issues that he may have, the more likely it might be that we would offer him active surveillance, which is just, close monitoring of his PSA, maybe getting some repeat biopsies. He may not need definitive therapy of his prostate cancer, and there has been a growing trend with that therapeutic modality. And in some men, brachytherapy or cryotherapy, which is freezing the prostate, is appropriate for a low-risk cancer. And then a lot of men get radiation as they get older, as they like the side effect profile of that as opposed to surgery.
And our approach is some men may have difficulty with urination, and they may benefit from an operation to remove the inner blocking part of their prostate so they can urinate better. But we usually reserve surgery to totally remove the prostate because of the potential side effects for it for younger men than 76 years of age. But as Paul said, one size does not fit all, and we have to look at the entirety of the man, what his desires are, what his other diseases are, before making a recommendation.
How often does prostate cancer metastasize?
Well, I would say that, going back to before PSA, men basically presented with either locally advanced disease or metastatic disease about 60 to 70% of the time. Now with the advent of PSA testing, a man presents with metastatic disease about 3% of the time. And so really the risk of metastasis has to do with what the therapies are once the prostate cancer has been diagnosed. So it's hard to really say how often does it metastasize, but certainly different treatment algorithms will result in different rates of metastasis. And if men choose not to have it treated, that very well may result in metastasis.
Peyronie's disease. Can you explain it, Jake?
Yeah, it's essentially a painful erection that doesn't resolve spontaneously. For all that this can be the butt of jokes, it's actually very discomforting for men and can cause some significant disability. It's in general practice, in primary care, I commonly think of it in terms of side effects from medication. In particular, there's a medicine called trazodone, which is sometimes used for sleep, which can have this as an adverse side effect.
The terms Peyronie's disease and priapism often get confused, and priapism is what we were talking about here. Peyronie's is really a curvature of the penis, which can also result in a painful erection as well. And there, it often will get better with time, and sometimes you need to have actually surgical excision of the plaque to help with that curvature.
Thanks.
What is a kidney stone, and what causes it?
Kidney stones are formed when the calcium salts in the urine are at a greater concentration than can be held in solution, and they clump together and form a stone. And they can achieve rather large size, but usually they are more in the size of an eighth to a quarter of an inch. And when they start moving downstream in the more narrow part of the urinary tract, they can lodge and cause tremendous pain. We have ways that we can help people by surgically removing these stones, or at times, if they're small enough, allowing them to spontaneously pass. Most kidney stones are not dissolvable with medication, so that we have to use some sort of other treatments than medical treatment.
One of the common misconceptions about kidney stones is that they inherently cause pain, and really it's exactly what Roger was saying, is as the stone descends and it actually causes the blockage, it's that blockage and the pressure built in the kidney that causes the pain. And one of the things, just to our viewers to be aware of, passing a kidney stone can be successful at home, but if you start having fevers or chills or feeling very ill, you need to call a doctor right away.
Quick question, Jake. Somebody wants to know what a colonoscopy is. We threw that name out earlier.
Yep, it's one method of looking at the inside of the colon or the large intestine for growths or tumors or polyps. Involves putting a patient to sleep and passing a flexible tube through someone's rectum into the inside of the colon to take a look.
Very good. A person's PSA went from 3 to 7 and his biopsy was negative. Why was the PSA so high? And I think we kind of touched on that. Do you want to just hit it real quickly?
Yeah, I mean, the PSA can be a moving target, and certainly You could have a very low-level PSA, and if it takes a sudden jump, that could be concerning for a cancer, but it may have been that there was a low-grade infection or inflammation. If that patient was in my clinic, I'd certainly talk about monitoring PSAs in the future to make sure that value came back down to baseline.
And the challenge that we have is sometimes PSAs can change 20 to 30% day by day. So you have to look at the big trend, not just a single value.
Well said. Nice job. I want to thank Dr. Ben Owens for his help in putting this program together in the past. And tonight I want to thank our panelists, Dr. Roger Miller, Dr. Jake Pernuski, Dr. Paul Tonkin, and our medical students, Tom Kaminsky, Ben Meyer, and Ben Weirs. Please join Dr. Ruth Westra for a program next week on women's health. Her panelists will be Jolene Finken, Melissa Stank, and Dr. Mark Widstrom.